Good evening, everyone. Welcome and thank you for joining this evening's webinar. My name is Melissa Bombick and I'm the CEO of the Facial Pain Association. Tonight, we are thrilled to host Dr. Michael Brisman, along with his colleagues, Dr. Ivan Mikulenko and Dr. Lister Wu. They will share their clinical experiences with the diagnosis, medical management, and operational treatment of patients with trigeminal neuralgia. I'm really grateful that you've taken the time to join us tonight. The webinar is being recorded and will be added to the webinar library on the Facial Pain Association website later this week. We'll also send an email to all attendees as well as those who registered but weren't able to attend the live event that contains a link to this recording. Before we begin, I'd like to share some updates from the FPA and go over a few housekeeping items. I want to start out by wishing everyone a happy Veterans Day, especially those who have served. We are honored to have you with us, and we thank you for your service. I'd also like to highlight our facial pain registry, which we launched in June. We launched this initiative in partnership with the National Organization for Rare Disorders on their I Am Rare platform. Today, 5 months later, we are very close to reaching our goal of 500 participants by December 31st. The registry provides a vital platform for people living with facial pain to share their experiences. By collecting this invaluable data, the registry can help drive medical discoveries and influence healthcare policy. By contributing your story, you'll play a crucial role in helping researchers gain deeper insights into the true impact of facial pain, ultimately paving the way for improved patient outcomes. Your data is well protected in this registry, and your unique experience is very important. I really hope you'll share it. There's a link to the registry on the homepage of the Facial Pain Association's website, and we're also going to drop a link in the registry for the registry in the webinar chat. We'll follow up again with an email, and if you feel inclined to participate, we'd love to have you join. Finally, I'd like to thank NSPC Brain and Spine for partnering with the Facial Pain Association. We are grateful for their support and their expertise here tonight. Now to go over a few housekeeping items. If you have questions, please use the Q&A feature at the bottom of your Zoom screen. We'll have a dedicated Q&A session at the end, but please feel free to submit questions throughout the presentation. We also encourage you to connect with other attendees using the chat feature. A lot of people often ask questions over in the chat, and that's fine, but it's easier to get to all of them if they are in the Q&A feature, and the chat feature is more for conversation. Now, it is my honor to introduce this evening's speakers. Dr. Michael Brisman is board certified by the American Board of Neurological Surgeons, a fellow of the American College of Surgeons, and specializes in the treatment of trigeminal neuralgia and brain tumors. He serves as the co-medical director of the Long Island Gamma Knife Center at Mount Sinai South Nassau in Oceanside, New York. Dr. Ivan Mikulenko is an experienced neurologist who has been treating patients with various neurological conditions, including neuropathic facial pain, for nearly 2 decades. He completed his medical education at the State Medical University in Ukraine, followed by a residency at the Johns Hopkins University School of Medicine in Baltimore, Maryland. He is a member of the American Academy of Neurology and the Neurocritical Care Society and the Johns Hopkins Medical and Surgical Association. Dr. Lister Wu has more than 15 years of experience in state-of-the-art external beam radiation therapy and gamma knife stereotactic radiosurgery. He brings a diverse background in community practice, research, and academic training to Mount Sinai South Nassau's Radiation Oncology Department. Dr. Wu completed his residency at Columbia University Medical Center in New York, New York. Again, we're thrilled to have you here and hope this session is helpful for you. Without further ado, let's get started. Doctors, please take it away.
Thank you. All right, we can load up the slides. Hi, I'm Dr. Michael Brisman. I'm a neurosurgeon. I practice in Long Island, New York. My specialty is trigeminal neuralgia and facial pain. I follow in the footsteps of my father, who was a giant and also a neurosurgeon and expert in trigeminal neuralgia. And I appreciate the Facial Pain Association giving me this opportunity, and I hope this will be helpful for people. Slide. Um, okay. All right. Well, I'm not sure if we're seeing, let's see, are we getting the slides up?
Let's see.
Okay.
I'm not seeing them.
Hmm. Well, if not, then we'll speak. I can speak without slides if we
Oh,
don't
there we
have them.
go. Here they
Okay.
come.
Okay, great. Okay. Maybe we could just maximize that.
Here we go.
Okay. All right. So trigeminal neuralgia is one of these diseases that I guess one could call either cranial nerve vascular compression syndromes or hyperactivity syndromes, where sometimes there's a blood vessel pinching into the nerve that causes the problem, and other conditions include hemifacial spasm and glossopharyngeal neuralgia. But we'll be talking today mostly about trigeminal neuralgia, which is affects the fifth cranial nerve slide. So there's a big differential diagnosis of things that can cause sharp facial pain. And again, this slide kind of shows a whole bunch of different things that could cause sharp pains in the face or the head. And I emphasize for people the importance of making the correct diagnosis, because there's one algorithm, one pathway of treatment for trigeminal neuralgia, and then there's a totally different pathway for other problems. Next slide. So there are also a whole bunch of conditions that can cause dull pain in the face, particularly dental pain, but there are a lot of other things as well. Trigeminal neuralgia is noteworthy for the sharp pain, but it also can have some component of dull and achy pain. Next slide. So certain features, it must be a painful condition in the trigeminal distribution, which is the face, the top of the head, the cheek, the jaw, and there's sharp, severe, intermittent, sudden brief pains that are often described as electric shock or stabbing. And this is the key. I mean, it has to have these things. This doesn't guarantee the diagnosis, but it must have these features. Next slide. It's usually described as electric shock or stabbing, can be described as often radiating, often triggered by light touch, often as spontaneous remissions, which means it could go away for weeks, months, or years and then come back, and almost always responds to tegretol or trileptal, also known as carbamazepine and oxcarbazepine. Next slide. Sometimes there can be other features like constant component or achy component that might make us call it atypical trigeminal neuralgia. But if it has the main features of the sudden, sharp, brief pains, we would still say that's trigeminal neuralgia, and that's going to be treated and managed the same way. Slide. The causes could be a blood vessel pinch in the nerve where it comes out of the brain. It could be multiple sclerosis, could be a tumor. And many times we don't know what the cause is. Next slide. Obviously, an MRI is done in patients who can get MRIs, which is most people, and that can sometimes give us insight into what the cause might be. The treatments can include observation. Medicines are the first line treatment, usually anti-seizure medicines like Tegretol or gabapentin, Neurontin. And then procedures, there's two main types of procedures. The microvascular decompression, where there's a small incision behind the ear. We go into the head and move the blood vessel away, which is appropriate if there's a compressive problem. And then the other procedures where we can injure the nerve a bit, because the pain is triggered by light touch in the face. So if we injure the sensory fibers by either percutaneous rhizotomy, where we put a needle in the cheek and injure the nerve a bit like that, or focused radiation, stereotactic radiosurgery, injuring the nerve, that can also disrupt the pain pathway. Next slide. So for the microvascular decompression, we want people obviously who we can see a compression. Usually we can see it on the new types of MRIs, the Fiesta or the CIS MRIs. Usually young, I mean, preferably under 65, maybe up to 70, healthy. Again, these are for people who do not have multiple sclerosis or a tumor. Ideally, they haven't had prior MVDs. It can be repeated, but it's definitely a higher risk. You're going through scar tissue. I think it's really a best operation to be done once. Ideally, good hearing on the other ear, because there's always a tiny risk of some muffled hearing afterward, and obviously some tolerance for surgical risk. Next slide. This is kind of a cartoon showing the main culprit is the superior cerebellar artery pinching into the trigeminal nerve. And then the slide on the right, it shows that there's a padding. The most common pad we use is the Teflon felt. And this is showing an interposition technique where the felt is still touching the nerve. And some people are saying maybe we should use a transposition technique where we push the artery away completely, and the felt where the foreign body isn't even touching the nerve, so there's no risk that the foreign body we put in will itself irritate the nerve or cause problems. Some people are talking about using other things besides the felt, like muscle or other substances, because sometimes the felt can itself cause a little irritation, although that's usually treated well with steroids. Next slide. This is just an image of one of my patients, just to show you. So here's what it looks like. We got a nice view under the microscope, but there on the left is the superior cerebral artery, really indenting the nerve is the white structure there. And certainly one could, imagine that that nerve might not work normally. And then on the right, you see the nerve looks straight. It's no longer being pinched and squished. And off at 10 o'clock, I put a little sponge. I did a transposition, and I put a Teflon felt and pushed the artery all the way away. So now the nerve is happy, and this person got better. Next slide. Other procedures to injure the nerve include the through the needle, the percutaneous, and the focused radiation. The percutaneous usually works faster, often immediately, though it can take a week or two. Often you can stop medicines completely, but it's a bit more invasive in that there's a tiny risk of bleeding or infection in the head, but very tiny. The radiosurgery, the focused radiation, can take a few weeks to work. And often you may still need some medicine, although not always. Often you can get off it, but it is certainly a bit less invasive. It's good for someone who can't come off blood thinners or can't have a procedure at all. Certainly, you would choose that. Next slide. So this just looks at the different types of procedures, and it points out that the radio frequency. So once we're in with a needle, we can either injure the nerve with radiofrequency, where we heat the nerve, glycerol, where we inject alcohol in the nerve, or balloon, where we squeeze the nerve with a balloon, or the focused radiation. The radiofrequency I like in some cases because it can be selective. We can injure just the third branch or the second branch, so just the area by the chin or the side of the nose. And it does need a little cooperation in the operating room. The others are non-selective and really aim at all three branches of the nerve, the three branches being the frontal, the forehead, the cheek, and the jaw. Compared to the MVD, they're all less overall risk, but the nerve injury procedures have more of a chance of needing a repeat procedure because the nerve can regrow, and also more chance of causing some numb or funny feeling in the face because we're purposely injuring the nerve, though that can occur with the MVD as well. Next slide. And this is just showing the anatomy, and the nerve is the yellow structure with three branches, and the third branch is the one at 6 o'clock going straight down, and that's where the needle can get in through the hole in the skull called the foramina valley, which just means the oval hole. And through that, we can access all three branches, in a very quick and short and non-invasive way. Next slide. Next, this is just showing, what it looks like with the needle coming in through the third branch. Next slide. And this is just showing a setup in the operating room where we're using live image guidance. There's the needle in the person's cheek. We sedate the person at the appropriate times. Next slide. This is just showing how the live image, and we can see the needle going into the skull base. Next slide. The principles of the nerve injury are that the more you injure the nerve, regardless of whether it's with the heat, the alcohol, the balloon, the focused radiation, and by the way, during the MVD is a decompressive and a nerve injuring procedure. The nerve is necessarily manipulated, and sometimes we purposely injure the nerve, particularly if we don't find a blood vessel at the time we're doing the surgery on the MVD. But the concept is that the more we injure the nerve, the more likely you get rid of the shocks of pain, the trigeminal pain, the more likely it lasts a long time, but the more likely you get problems from over injury, like numbness and dysesthesias, means funny feeling in the face. And smaller injuries can completely eliminate the pain. And it's hard to assess at the time we're doing the procedure how much injury. So I think generally we err on the side of doing less rather than more, although again, it's not a completely exact science. Next slide. The stereotactic radiosurgery, the focused radiation, the key features are that the focused radiation is very conformal to the target, in this case, the nerve root, and there's a rapid fall off of the radiation, so there's not much radiation to the rest of the brain. Next slide. So we use different machines, but usually for trigeminal neuralgia, we're using this machine on the bottom right called the Gamma knife, which uses gamma rays. Sometimes other machines use like the Cyber knife or TrueBeam, which uses X-rays, but it's the same general idea. Next slide. And the focused radiation, I use it also on brain tumors, AVMs or vascular malformations, other things, but it has a wide variety of uses. Next slide. And this is just showing a treatment plan that I did on a patient where the green is where we're the target of the radiation on the nerve. You can see on the right is where we're targeting the nerve. And this person had good relief for, 15 plus years and did very well from this. Next slide. So for people who have facial pain that's not trigeminal neuralgia, and sometimes this includes people who have trigeminal neuralgia but have had treatments that have injured the nerve and now they have other types of pain, like a constant achy pain. These include observation, certain medicines like gabapentin, Lyrica, Elavil, nortriptyline, Topamax, Cymbalta. It can include low dose naltrexone, steroids, Tylenol, Advil, hot things, cold things, uh, all sorts of things. Medical marijuana. Is a last resort. We can do certain neurostimulation procedures. The key point here is that if it's not trigeminal neuralgia, most of these are 99% are managed without an operation. That's the key thing. The operation can maybe be done as a last resort, but these problems, and by the way, a lot of people have craniofacial, have headaches, pain in the face, pain in the head that is not trigeminal neuralgia. So very critical to get the correct diagnosis because these are treated differently. And by the way, there is always hope for people. There's always new things coming out and different people respond differently. You just got to keep trying things. Next slide. So the points I want to emphasize are key principles, correct diagnosis, very critical, flexibility of treatment. I think it's helpful to have be able to treat with medicines, with gamma knife, with radiofrequency, glycerol, balloon, MVD. I personally do all of these. This is my specialty. I've treated thousands of patients. I think that helps. Avoiding complications is a key principle because you can always come back and do more. And I think the surgeon experience is also critical. Having someone who specializes in this, I think, is much more likely to get the right diagnosis, help you on the right path better. Next slide. Thank you very much. And I'm always available. I do, anyone wants to call me on my cell phone, it's 516-319-7451. You can email me at michaelbrisman@aol.com. I do FaceTime consults or other calls. We have no secrets. We want to help people anywhere in the world. Anything we can do to help you, let us know. And as a person, I actually have learned a lot about pain the last 7 years or so because I've suffered from my own chronic pain that's been terrible, and I've come out the other end. And I want people to know that there's hope. And one of the things that helped me was all the nice doctors and nice people who were there to help me. And as a result, I have much more insight, more empathy than I ever had, and I want to help people out to feel better, and that's what life is all about. So I hope this was helpful. Anyone needs any help, you let us know. And I'll introduce now Dr. Wu to give a talk on focused radiation treatments for trigeminal neuralgia.
Thanks, Dr. Brisman. Appreciate it, and appreciate the Facial Pain Association for having us on this live broadcast. If I could have my slides up, we'll get started. Okay, great. So today, my main focus is to talk about radiosurgery and the treatment of trigeminal neuralgia. As Dr. Brisman hinted at, Gamma knife is the predominant modality that we use here at Mount Sinai South NASA. So I may pay special attention to Gamma knife and its history and some of the results of treatment. Next slide. Here's my obligatory disclosure slide. Next slide. So again, I want to briefly go over definitions of what stereotactic radiosurgery means, because sometimes there's a bit of confusion that's out there. We'll review, what's involved in a gamma knife procedure, and then talk a little bit about literature and the efficacy of stereotactic radiosurgery in the treatment of trigeminal neuralgia. Next slide. So it's a confusing landscape out there. There are a lot of machines, and now they all have different names that are very catchy. It's kind of, I always equate it to being out there and trying to shop for a car. Everything is attractive but the bottom line is, all these machines that you see pictured here and some more that I haven't included, they all can provide stereotactic radiation therapy. It really depends on, your utility of it and, your experience using it. The gamma knife, as you saw in Dr. Brisman's slides on the bottom right, that's where I'll pay most attention to. Next slide. And so what is stereotactic radiosurgery? So by definition, at least through the government, it's basically it's a treatment method. It's a radiation treatment method. We deliver a high dose of radiation to precisely to a target. And we either use one single dose, one large dose, or we do a few large doses. And obviously precision, image guidance, those are really paramount in delivering this treatment safely and effectively. There are a lot of different names that are out there that you may read or come across, when you're doing research. For example, SRS, probably most commonly used, stands for stereotactic radiosurgery. And technically that means the treatment is delivered in one dose. There's FSRS, or fractionated stereotactic radiosurgery, where instead of one dose, you may do up to 5 treatments. Some people might do 2, 3, 5, 4, something along those lines, but that's still considered radiosurgery. And then there is also an acronym that's out there that's SABRE. And, some people in our enterprising people in our field have used that to stand for stereotactic ablative radiation, just because it sounds sexier or sounds more catchy. But essentially, that's used interchangeably with stereotactic radiosurgery or fractionated SRS. Next slide. So what is the gamma knife? Sometimes people, perceive gamma knife as some kind of surgical tool. And the first thing that I always tell them is, I'm not a surgeon. So this is not a surgery, but it basically uses precise beams of X-rays. In this case, it's gamma rays, just because the energy level of these rays, which is, immense, happens to be in the gamma range. That's why, we use, they're called gamma rays, and that's why it's called gamma knife. But it's using these tiny beamlets that are arranged in a hemispherical arrangement around the head to deliver radiation precisely. And because the dose is divided out over so many beams, each beam actually carries with it a very tiny amount of radiation. That's how we're able to achieve precision, and at the same time avoiding essentially any collateral radiation going to surrounding brain tissue. This is a team approach when we use gamma knife. There's a neurosurgeon, there's a radiation oncologist, we have a team of physicists, nurses, and even an anesthesiologist when necessary. Next slide. So in gamma knife radiosurgery, typically there's some kind of an immobilization device that's put on, whether it's a head frame or some kind of a masking system. So that's what you see on the left. Then we proceed to imaging, which gives us the ability to localize what we want to treat. So in the case of a trigeminal neuralgia, we want to target the trigeminal nerve. Now, this may reproduce very small, but this is, where you see the arrow is basically where, in this case, the patient's right trigeminal nerve is, and where we target with the radiation. Next slide. It's a cartoon of what happens with gamma knife treatment. So the patient is essentially placed on a bed. The bed moves into this conical shaped area, and that's where all the sources will emanate from. And there's a very precisely controlled system of what we call collimators, which essentially are tiny doors that open and close those 192 beams, to accurately and focally treat the area. One of the things that patients will often ask is it as confining as an MRI? And what you can see here is that it is not. And it certainly is silent, doesn't have any banging noises like the MRI does. Typical treatment time is anywhere between 30 to 60 minutes on average. Next slide. So where we treat, if you remember in Dr. Brisman's slides, one of the things that he had mentioned of is when we use radiosurgery, we don't necessarily discriminate between the different branches of the trigeminal nerve. And that is because, the idea is to treat at the root of the trigeminal nerve before it branches off into its three subdivisions. So we deliver the radiation to the root. Doses are typically between 70 to 90 gray, and that's just our unit of radiation. And this is generally the dose range in patients who have not had radiation before. Next slide. I thought this was kind of interesting. Oftentimes people ask, well, how does radiation work? And there's a lot of different theories that are out there. This was an interesting paper. It's not that new now, but they did tractography, which basically is mapping of nerve action. And one of the proposed theories is perhaps that the radiation disrupts the myelin sheaths. Think of the myelin sheaths they're kind of like the insulation of the nerve. So if you have insulation on an electrical cable, you have insulation on the nerve. And basically, it's thought that maybe radiation interrupts some of that, which makes it conduct, the nerves conduct more poorly. Another theory is that at between the nerves at the axonal level, the transmission in those interspaces is disrupted by the radiation. Next slide. So in terms of results for trigeminal neuralgia treated with Gamma Knife, now the vast majority of the literature that's published over the last 3-4 decades is almost all Gamma Knife, and that's because the machine has been around longer than any other treatment modality. So it's well vetted, and has a vast vast array of papers that have been written. But in general, about 75% of patients report some degree of pain relief. Now that can be partial, that can be complete, but in terms of some kind of a positive response, we always will quote to patients 75% will typically have some kind of relief. And after 5 years, the majority of those patients continue to have durable pain relief. Obviously there's some patients that may need repeat treatment. And in those cases, we often will tell patients that a second treatment doesn't mean that your chance of success is any worse than the first time around. I always tell them that it's another 75% chance that they can have relief if they have a repeat treatment. And as Dr. Brisman had hinted at, the one thing that sometimes patients are surprised by is that the response of trigeminal neuralgia pain to stereotactic radiosurgery is latent. There is a lag period. I wish I could say that, the instant that the patient comes out of the machine, they start feeling better. But on average, we say about 6 weeks. But remember, that's an average. There are patients that Dr. Brisman and I have managed in the past where, they started to feel better at 1 week, 2 weeks. And then there are some that may take longer than 6 weeks. So the key thing is that patients should remain on their medication regimen until they're sure, or their doctors are sure, that there's something positive that's happening. Next slide. What are some of the side effects? So, thankfully, it's not that great, and it's fairly minimal. We'll always counsel patients that there can be changes in sensory of the trigeminal nerve in about 10% of patients. And so it's not a high number, but it is still something that we have to watch out for, and it's something that in follow-up we continually ask the patient. And then also, fortunately, what's nearby to the trigeminal nerve, or the root of the trigeminal nerve, is the brainstem. There is obviously other nerves that are nearby: facial nerve, acoustic nerve, and injury to those structures, although they are relatively close, is rare, just because the focality and the precision of the treatment, especially with Gamma Knife, really prevents that from happening. Next slide. So generally, in summary, who's a good candidate for stereotactic radiosurgery? So patients will always start on some degree of medical management, but at some point they may reach a point where it's not optimized. And, they may be maxed out on the medications. They don't like the way they feel, or it just doesn't work anymore. And that can be sort of an escalation from, the least invasive, which is medicines, to one of these more slightly invasive, but not quite yet, to more invasive therapies. Patients who, let's say, are not candidates for something like MVT, or they don't want a surgery, they could be considered for stereotactic radiosurgery. And then obviously patients whose pain is refractory, despite the best efforts of their doctors, either through rhizotomy, through medical management, even in patients that may have gone through MVD, an alternative approach sometimes can be beneficial. And again, stereotactic radiosurgery outside of medical management is considered one of the least invasive treatments that can be offered. Next. And that's all I had to say. Again, we're very accessible. There's my phone number. Definitely feel free to reach out if you have any questions. Thank you.
Thank you,
Okay.
Dr. Brisman. Thank you, Dr. Wu. Thank you, Dr. Mikolenko, for being here. We have a ton of questions, so we'd love to get right to them. I will tell everybody watching, we received several questions before the webinar started, and we're going to kind of take a mix of those as well as the ones in the Q&A box. And then we are going to follow this webinar up with probably a podcast or something that answers additional questions. So we will be getting to that as well. One of the questions that I've seen a couple posed a few different ways talks about people that have trauma-related trigeminal neuropathy that is non-responsive to treatment. So this question says, how should post-surgical or trauma-related trigeminal neuropathy be treated when pain worsens instead of improving? And we have other questions about people who have had dental injury or injury due to surgery, or even trauma to directly to the face. So how should that be treated, and who is the right doctor to go to in that case?
Maybe let's start with Dr. Mikolenko. So the question's about managing trauma-related trigeminal neuropathy, pain in the face. Ivan, how do you manage that?
Yeah, I have a patients all the time coming is let's say from the dental procedure. Lately, implants were very popular, and they place implants very close to where the trigeminal branch runs. Then again, the after trauma. So the first step would be, of course, uh, get a good history what happened, get the imaging. I usually order MRI, and I like this is a special MRI with a Fiesta study, which we look closer to not only on the cranial nerve 5, but other nerves. And then from the first appointment, we try, if we, from the history and symptoms, we establish as most likely it's trigeminal neuralgia. Doesn't matter, it's from the injury or other causes. We try medication. And we go, the most common is, you, Michael, mentioned trileptal, carbamazepine or carbamazepine. I like to add gabapentin or dilantin. So we start with the medication. We wait for what MRI is going to show, and then we go from there. If we find any lesions on MRI, which might be the cause of the pain, that I consult Michael, and I send him patient for consultation. I send him imaging, and he will decide if patient is appropriate for any surgical treatment. But of course, the first step is medical management, and good history is very important. What exactly happened to patient?
Okay. Dr. Brisman, anything to add to that?
I agree that if it's clearly an injury-related pain, which often has features of like the pain happens right after the injury. There may be numbness. It's mostly a constant achy pain. Those are almost always managed with medicines. And as I've mentioned, gabapentin, Lyrica, Cymbalta, nortriptyline, topical pain creams I sometimes use. And again, anything that is going to ease your stress, improve your mood, relieve your anxiety. And there's a whole list of different things that one can do. Um, but now, again, final option, sometimes for those kind of pains, like these stimulators, like sometimes you put a little stimulator lead here or here, and it can almost be like an internal TENS unit. But the major management, once you've ruled out everything, is going to be non-surgical.
Okay. Thank you. Dr. Wu, a question for you. Somebody was asking about how often you can have the Gamma knife procedure, but then there were several other questions about some of the more ablative procedures, and that might be for Dr. Brisman. Do they seem to lose efficacy with repeated efforts? So I guess first, how often can you have the Gamma knife procedure?
Well, I would say certainly twice is reasonable, and I think that's usually how we start off. Now we don't necessarily um, uh, want to do the second treatment within a short interval from the first. So if someone undergoes gamma knife procedure and 3 months passes and they're back to the same level of pain, it's not that at 3 months we're going to go for a second treatment. We always worry about damaging or providing so much radiation that we damage the nerve and they have a sensory deficit. So a lot of times we wait 6 months, 12 months at a minimum before considering a repeat treatment. Um, the the main thing to note is that the trigeminal nerve generally has essentially like a lifetime tolerance. It does remember, the dose that it received in previous, treatments. And so we don't want to exceed that sort of a lifetime treatment dose. And so, when you treat the second time, you're not going to exceed it. There are select times when, we'll see if a patient, let's say, had 5 years of durable remission after the first, 4 years after the second, and then they come back for a third. Well, that patient has maybe a track history of responding well to radiosurgery. We might consider a third, but it's not by and large something that is routinely recommended to everyone. Um, as far as losing efficacy over time, I think that's kind of a function of, well, as you try more multiple treatments, your window of dose starts to get a little bit tighter, and so obviously there's a dose response relationship, and so I think if we were confronted with a situation where we're thinking it's diminishing returns, we're going to turn to someone like Dr. Brisman, to think of some other ablative procedures.
Okay. And quickly, let me ask you too, does radiosurgery have any effect on occipital neuralgia? Is it helpful there too, or are you specifically looking at trigeminal?
So, we've typically used it primarily in trigeminal neuralgia. There have been cases we've done for glossopharyngeal neuralgia. I've not seen a case of occipital neuralgia. Mike, I don't know if you can weigh in on this, but that's not something that I'm aware of, or even in the literature.
Okay.
Yeah, I mean, definitely a literature on trigeminal neuralgia and glossopharyngeal neuralgia, but I'm not aware of anybody doing focused radiation for occipital neuralgia. I'm not even sure what the target would be, but
Yeah.
I'm not aware that people are doing that. And I would say that's, clinical trials for that.
Yeah. And Dr. Brisman, what would your answer be as far as the efficacy of ablative procedures with multiple, treatments, repeat treatments? Do they reduce over time?
Okay, so there's three different types of treatment. I mean, so the gamma knife, and they're all kind of different the way they work. I mean, gamma knife, the second time you want to wait at least a year, but ideally two, because you can see changes and relief and issues that happen. I'd say even up to 2 years, you can start to see that. And then you can consider a third, but it's got to be way down the road. Like today, I had a patient who had a gamma knife in 2007, then 2010, and did well for for 15 years. I mean, he could get a third if he wanted. As far as the needle procedures, those can be done as many times as you want. I mean, so the radiofrequency, I mean, you could do that. I have patients like with multiple sclerosis that need it frequently. I mean, you could do it 5, 10 times. So that can be done as many times as you want. And it can continue to work. The issue is what it works on is the trigeminal neuralgia pain. If they have sudden, brief, severe shocks that are triggered by touch, that can still be effective regardless of how many times you do those procedures. If you do multiple procedures and the person ends up with new types of pain from the procedures, I mean, if they say, look, I have a numb feeling, I have an achy feeling, that isn't going to get better from another denervation. And same thing with MVD. I mean, I think it's best done once. I mean, once you start going back a second time, you're working through so much scar tissue, you're mostly, injuring the nerve. But again, I think you can continue to get relief from nerve injuries, but you have to just be careful when you do over and over, particularly with MVD, repeat MVDs or repeat radiation, that you not overshoot it because that's, it's always a balance.
Okay. Thank you. We hear a lot about Ehlers-Danlos syndrome as a comorbid condition with trigeminal neuralgia. So there's a question in here about does having Ehlers-Danlos syndrome affect the benefits or risks of any treatment, medicinal or surgical?
Michael, I
Sure.
had a few actually patients. It's not that rare, but I had a few patients with Ehlers-Danlos syndrome. It cannot directly affect trigeminal neuralgia, but this disease affects connective tissue. And for example, if patient has, many people have a problem in the neck, and that might affect the trigeminal nerve indirectly. Secondly, it might affect vessels around the brainstem, and that's might lead to trigeminal neuralgia. So once again, it's not very often, but it is connection between the Ehlers-Danlos syndrome and the trigeminal neuralgia.
Okay. We have a couple people who have asked about pain in their eye, like almost like a stabbing pain in their eye. So is that something that would be also considered trigeminal neuralgia, or is that a different diagnosis?
It can, so I'd say it can be.
Hmm.
I mean, so that's in the trigeminal distribution. So if it's, a light touch to the eye or around the eye, and a person gets a sudden, brief, severe, excruciating electric shock or jab in the eye, I would say, and it gets better completely with Tegretol, I would say that could be trigeminal neuralgia. I mean, there are other things it certainly could be. I would say see the eye doctor. I mean, there's certainly other things. And the other thing to consider is these trigeminal autonomic cephalgias. Anytime the pain is primarily in the eye, you want, and maybe if there's autonomic features, there's tear in the eye, redness, drooping the eyelid, you have to wonder, is this SUNA? Is it SUNCT? Is it hemicrania? Is it cluster headache? So again, it can be trigeminal neuralgia, but again, you have to go see a specialist and be sure that's what it is. But if it's, and I'll say the trigeminal neuralgia is usually mostly the lower face, like the cheek and jaw, and it involving just the eye or just the forehead in just the first division. Only maybe 2% of trigeminal neuralgia patients have only that. So where it's just stabbing pain in the eye, but it can happen.
Okay. And if you do have one of those other diagnoses, what doctor do you go and see then?
Well, we could see different people, but I mean, so the key diagnosis for hemicrania is an absolute response to indomethacin. So if you have sharp, severe pains in and around the eye, and the person has autonomic features like tear in the eye, redness in the eye, drooping the eyelid, and they get completely better with indomethacin, it's hemicrania. They just get managed with indomethacin. If they have the pains last for 3 hours and this prominent, symptoms. It could be cluster headache. That's managed differently with verapamil, something else. And Sunctin Suna, which which is primarily eye autonomic features. A lot of people, myself included, think that that's kind of the same as trigeminal neuralgia with autonomic features, and that one can consider trigeminal neuralgia procedures for those. But Ivan, what do you think about what I said? Or do you have thoughts on these things?
Yeah, I agree. But I tell you, to answer the question, what kind of specialist to go see? So, from my experience, they usually already saw the ENT doctor. They check all of the sinuses and everything. If there is a pain in the eye, then they saw the ophthalmologist who did a very thorough exam. Everything is normal, and then they saw the dentist. And I am in my specialty. I'm usually the last one. They already saw 3 to 5 specialists, and then they send it to neurologist to
Right.
decide what's wrong.
Interesting. Okay. We have a couple of questions about MVD. Is there an ideal time or age to do that? We have an 87-year-old patient who says their neurosurgeon is considering an MVD, and is that appropriate or inappropriate? And then also, what was the other question about MVD? Well, go ahead and answer that one, and then I'll find the other one.
Sure. So, I mean, there's no absolute rule about what age. I would say, first of all, critical to have the right diagnosis. I mean, if you don't have trigeminal neuralgia, the MVD will not help you. Second is, I think the MVD is going to be better if there's clearly compression from one of the cerebellar arteries. If there isn't, then your benefit is just because you manipulated the nerve, and that's more likely to come back. As far as the age, I mean, most people look to about 65 or 70 as kind of the upper cutoff, but it's not absolute. I mean, the issue is that as you get older, even if you think you're in perfect health, you're not. I mean, just like, if you had to cross the desert in a brand new car or a car that's 30 years old, which would you take? I mean, you would take the new car because the older car is just more fragile. You're more at risk when you're 87 of a heart attack, a stroke, something like that. The only time I've really done an MVD in someone, in their 80s is if they were really refractory to the gamma knife, to the rhizotomy, or if it was a strong patient preference. But again, I start to get concerned over 65, 70 because, as a person gets older, I mean, there's risks of other things. It is a bigger operation. And so again, I'm not, any of these can be done at any age, but I like MVDs up to about 65, 70, unless the patient really wants to push it. I mean, if you're 87, I would think seriously about trying one of the other procedures.
Dr. Wu, do you think the older you are, is it a response to gamma knife therapy is worse? So with the age, is it better
Yeah.
response in younger people than in older people?
I will say, most of our patients are in the older category, so I may have a skewed sense, but of the patients that are in the range that we've just been talking about, 80s. I'm thinking that Dr. Brisman, I may have had a patient in their 90s actually, but we tend to see a variety of responses, and some of our best responders have been in the elderly population. So I think it's one of these things. It's very hard to predict, whose nerve is going to be more responsive than not. I think that's one of the big challenges, is not to have a more predictive method or model, to see, who is best fit for what modality. But to echo what Dr. Brisman says, at least from a radiosurgery point of view, the fact that it's less invasive means that it can be a good alternative in those patients where maybe surgery incurs more risk, or they want something that is better than just medication, but at the same time not have to take on something that whether through anesthesia or healing or whatever the case may be, is going to be riskier than their disease.
I think you have to look at general health of the person, because sometimes you might have an 87 years old looking much better than 67 years old who has already diabetes, kidney
Yeah.
problem, you
Yeah.
name it.
That's
Right?
right.
Would you agree?
Absolutely.
Right?
Absolutely.
Absolutely. Okay. All right. Dr. Wu, I do have a question for you. Can Gamma knife be an option for trigeminal neuropathy secondary to dental injury?
Mhm.
Mm. So I would say, we have more of a narrow focus of where we think radiation is appropriate. So obviously classical trigeminal neuralgia, even atypical trigeminal neuralgia, those are probably the ones where we feel that the effectiveness is best vetted. I mean, on occasion, there are some patients that we'll see that have like post-herpetic trigeminal neuralgia. And in those cases, you have to caution them that the effectiveness is maybe not going to be as great, just because, it's a different mechanism, just as you've been hearing, facial pain is very multifactorial and trigeminal neuralgia is only one of them. So, Melissa, to answer your question, I would say, it's one of those things that, we would encourage such a patient to try to explore, all other options, medical management and some of these other procedures. I look at radiosurgery as maybe one of those choices that are towards like last resort. Yeah.
Mhm.
I don't know. What do you think, Mike?
Yeah, to me, if you don't have trigeminal neuralgia, this isn't the way to go. I mean, because the reason trigeminal neuralgia, the nerve injuring works, is that it's almost always triggered by light touch. So if you injure the sensory fibers a little bit, you can disrupt the pain pathway. For people who have nerve injury or anything else, the nerve's already injured. If you injure it more, you often just make the problem worse. So I kind of think that dental injury is not, and in fact, anything else, I don't really think it's good for anything but, the only type of trigeminal distribution pain is trigeminal neuralgia. Anything else, I think the focus radiation is not the way to go.
I think with the dental, pain in the face caused by after a dental procedure, you always have to give a bit time. I always tell patients, wait when all of the inflammation and everything goes away after you had the implant or whatever dental procedure was there. Give it a little bit time, and I tell you, 90%, after 2, 3 months, they don't come back to me because pain is gone.
Mhm. Okay. Okay. Can you talk about how stress plays a role in trigeminal neuralgia and why? We have many patients that talk about how their TN flares with stress and in this case lack of sleep. And then I also want to talk a little bit about very common triggers for TN. People are asking about those as well.
Well, look, I think stress is a big factor in anyone with chronic pain, or people without chronic pain. I mean, there are a lot of, stress, depressed mood, anxiousness. These are kind of things that will make any kind of pain problem worse if you have them. And if those things aren't part of your life, they're going to make your problem better. And part of the issue is that pain and any problem we have is really always two problems. I mean, it's, one is that you've got the pain, but the other is that it bothers you. It's like the difference between pain and suffering. And like if we could make the pain not bother you, then that's part of it. And a lot of things when you're stressed or upset or anxious, your pain becomes more bothersome. That's just how the brain works. And if everything is going your way, you're distracted, you're happy, you're celebrating, then your pain is one or two notches less. So I think anything that can be done to calm your body down and address all the other issues in your life is going to help with this. Also obviously trigeminal neuralgia is set off by contact. So if you're, like let's say you have a cold and you're sneezing, you're touching your face, or anything is causing you to touch your more touching of the face, that may set it off more than if you're in a calm situation and you can avoid regular contact. But
Okay. Okay. Um, we have a lot of questions about pain in the jaw, pain in the mouth, pain in the tongue, sharp pains. And this question in particular, would sharp pains in the tongue presenting with the jaw pain be part of TN symptomology? Is that Or is that something different? And then also just a general question about burning mouth syndrome. And then we always get questions about anesthesia dolorosa. So can you discuss those conditions a little bit?
So, well, the sharp pain in the tongue or jaw could be trigeminal neuralgia. Again, if it's sudden, triggered, brief, excruciating electric shocks that disappear with carbamazepine and it's in your tongue or jaw, that's a trigeminal distribution, and that certainly could be trigeminal neuralgia. As far as burning, and would be treated along the trigeminal neuralgia algorithm. Now, if you have sharp pain in your jaw and you had a shingles outbreak, well, that's not, or you have sharp pain, but you also had a procedure recently in your jaw and you have numbness and burning and that's also could be something different, but that could be trigeminal neuralgia. Burning mouth is not trigeminal neuralgia. That's usually a constant burning aching pain that can be on both sides of the mouth, and that is treated differently. Anesthesia dolorosa is when you injure the nerve, whether it's treating trigeminal neuralgia or doing anything. You're getting a procedure, you're having a nerve, and the nerve gets injured. You can get numbness, you can get achiness, you can get funny feelings. I mean, anesthesia dolorosa is an extreme end of that. So that's if you have an extreme injury to the trigeminal nerve, whether it's to try to help your trigeminal neuralgia or it's from some other injury, and you're left with complete lack of feeling anywhere in the face, and coupled with very bad achy burning pains. That's just like the extreme end of that, and even that there are things that can be done that might be helpful, but we try to avoid obviously that by deliberately trying to minimize the injuries that we do.
Mhm. And if they are dealing with that, what kind of things can be helpful in those cases? Because we get a lot of questions about those.
Yeah. So again, the first best thing is always avoiding having that happen, and there are a lot of things to do to avoid that. But otherwise, I think it's again things like gabapentin, Lyrica, Topamax, nortriptyline, Cymbalta, reducing stress, reducing anxiety. Low dose naltrexone, medical marijuana. I mean, all stimulators, but it's all those things. Ivan, do you have any other ideas what one can do about that? But I think it's that category of stuff.
Yeah, people tried everything, including like CBD oil. Then even simple acupuncture sometimes my help. Like I had the people who tried everything. That they went to good acupuncturists, then the pain was gone. So I see a lot of questions here coming for the Botox. And is that Botox has any place in the treatment of trigeminal neuralgia? And there was a few cases I saw in the literature that I have many. I do Botox on a daily basis for chronic migraine. Then I have people with bruxism, which they crush in their teeth when they sleep. So we do Botox injection in the area of masseter muscle, which is very close to and the temporal area. So there was a case that described then when people they had a trigeminal neuralgia, they had a bruxism, and when Botox was injected in the area of masseter muscle and the temporal area, the pain got better. So it definitely, probably like try and go basis Botox, but there is no complete indication. Botox now used a lot in different treatment of the, but I would definitely try. Nothing helps. I would try Botox.
I think the Botox can be used for trigeminal neuralgia or any other pain. I mean, it
Right.
can work for a few months. One mechanism is by weakening the muscles, and there may be muscle spasm associated with pain, but it also works in ways that aren't completely clear, just directly to reduce pain. So I think it's something definitely that one, a very low risk, that one could definitely try for trigeminal neuralgia or any kind of refractory craniofacial pain syndrome.
There you go.
Excellent. Well, we are coming to the end of our time tonight. I want to let everyone know that we do have, we are planning a podcast to go ahead and go through some more of these questions. We'll compile them and sort of combine them so that we can try to categorize them and get through them and make sure that we can get some answers to these. I want to end and just ask if there are upcoming procedures or treatments, anything new, things that that people might not know about that is providing hope for you and for your patients. And I'll just ask each of you, Dr. Brisman, if you want to go ahead and start.
There are so many new things that are going on with me. I mean, I'm working on creating new questionnaires for patients to try to best pinpoint the diagnosis, because a lot of this diagnosis, remember, is based on the questions and answers. There's no blood test for it. I'm doing new neural monitoring investigations during the operation. We can measure different things. There are different trigeminal reflexes that we think may be uh, demonstrate if the nerve has or hasn't been successfully decompressed. We're measuring sensory function of the nerve so we can assess during the MVD exactly how much injury is there. We're trying, different medicines and different treatments, and even the percutaneous treatments. Different amounts of heat, different amounts of time, different amounts of alcohol, different combinations. So I would say we're really trying a whole bunch of things, and I'm looking to publish some things, but I would say it's an obligation for us to try to advance the field since we have such a large experience with it. But I see a lot of exciting things that I'm working on every day.
Absolutely. Thank you. Dr. Mikulenko, anything for
Uh,
you?
yes. I just want to say one thing that neurologist has to work very closely with other specialties. So number one is neurosurgery, especially in people with refractory facial pain. It could be, as Dr. Michael Brisman says, it could be not only trigeminal neuralgia. We can discover a different cause of it, but this is diseases which require a team effort here, including neurology, neurosurgery, ENT specialists.
Excellent. Thank you. Thank you. Dr. Wu, anything to add?
So, I think there hasn't been a lot of development. One of the things that, may be of interest with regards to radiation is, we've talked about delivering the dose in one big shot, but what if you deliver it in pulsed, separated, what we call dose stages? That's one interesting aspect to consider. The other thing too is, in this age, everyone's hearing about AI. One of the benefits of AI, I think, when it comes to clinical research, when you have a database of like thousands of patients with very different clinical characteristics, especially with trigeminal neuralgia, and you're treating them with something like radiation, is trying to maybe find a way to develop a more predictive model and who's going to be more successful going through treatment. One of the things that AI can do, that couldn't be done before is it can churn through lots of different clinical parameters and find relationships that you couldn't do with a statistician under normal circumstances. So I think that's one area that I would probably want to explore, with all the data that we have, to see if we can come up with a better predictive model so that the patient that comes in before us, we can give them a better idea of what might we guess their success rate might be. Yeah.
Excellent. Okay. Well, I want to thank all of you for taking the time tonight to be with us. I mean, we're really grateful for your presentations, for your expertise, for taking the time to answer these questions. Really appreciate your time, and thank you very much.
Thank you.
And thank you to everybody who attended
Thanks a
tonight.
lot.
Again, we'll follow up with links to the recorded webinar and hopefully answers to some more of these questions. So stay tuned to our biweekly bulletins, our social media, and emails that come out. We'll make sure that everybody knows what's coming up. Thank you again and good night.